Hello and welcome to this webinar about the AGA Digestive Health Outcomes Registry. I am Debbie Robin, Senior Director for Quality at the AGA, and I will be your moderator. We are very fortunate to have with us today three speakers who have been instrumental in the development and implementation of the AGA Registry. First, we will hear from Dr. Joel Brill, who will provide an overview of the registry and its benefits to practices. Next, Dr. John Allen will talk about the measures for the registry, and finally, Mr. Joe Lynch will discuss the technical aspects of the registry. Just a few housekeeping items before we begin. If you would like to submit a question during the presentation, type it into the question box on your screen. Questions will be answered by our speakers following the presentation. This session is being recorded and will be archived at the AGA Registry website within a week at www.agaregistry.org. Now, without further ado, I will hand the floor over to Dr. Brill.
Thank you, Debbie, and thank you everybody who is joining us today to learn more about the AGA Digestive Health Outcomes Registry. Debbie, could you advance the slide, please? And as Debbie has mentioned, Dr. John Allen and Joe Lynch from MedAssurant will be joining us over the next hour's time. Next slide, please. So what is the AGA Registry? It is currently the largest outcomes registry devoted to gastrointestinal conditions. As of May of this year, the AGA Registry contains data from over 4.38 million patients. The registry is a partnership between the American Gastroenterological Association and MedAssurant, and it currently represents the largest independent healthcare database in the United States based on MedAssurant's MoreSquare database. The registry supports outcomes-driven quality improvement. It can help you to demonstrate resource efficiency. It will help practices to manage your patient populations. The registry is a certified portal for Medicare's PQRI incentive funds, and it will help to create a gastroenterology learning community. Next, please. MedAssurant's MoreSquare database is based on longitudinal claims representing data from over 200 health plans covering over 56 million people. There is data including patient demographics, pharmacy claims, medical claims, laboratory claims, diagnosis codes, pathology, comorbidity, and DME claims. From that database, the AGA registry has been developed containing records from a period of 2005 to 2009. Within that baseline part of the registry, there are claims in over 300,000 people with inflammatory bowel disease, representing over 140,000 with ulcerative colitis, 120,000 with Crohn's disease, and 40,000 with unspecified inflammatory bowel disease. In addition, we have data on patients who have undergone colonoscopy for colorectal cancer prevention of over 4 million patients. Thus, this database is longitudinal, and it contains an extensive breadth of data across genders, age, geography, and payer types. So there's data there from Medicare Advantage plans as well as from commercial plans, and some Medicaid plans as well. Next slide, please. So why would you want to participate? Well, all of us want to do a good job. And one of the benefits of participating in the AGA registry is to be able to join a learning community of gastrointestinal practices dedicated to better patient care. Through participation, you will be able to receive reports which benchmark your outcomes to other practices or to the entire registry database across the country. You'll be able to manage your patients at a population level. That means that you'll be able to look at all of the patients in your practice if they're entered into the registry. You will be able to become eligible for payer incentives and recognition through both Medicare's PQRI program as well as through some commercial payer initiatives. And one of the further participation will be to achieve maintenance of certification. Next, please. Quality and cost have become some very important buzzwords, both in as well as outside of the Beltway. Dr. Don Berwick, who is the administration's nominee to become the head of Medicare, talks frequently about the triple aim of the IHA program. And the triple aim talks about improving the patient care experience, improving the health of our population, and reducing the total cost of care. In addition, Dr. Edwards Deming, probably the father of quality improvement, said when people and organizations focus primarily on quality, quality tends to increase and costs fall over time. When people and organizations focus primarily on costs, costs tend to rise. Quality declines over time. That is no more apparent than in MedPAC's report to the Congress released yesterday. Clearly, incumbent upon us as gastroenterologists to help to demonstrate quality in an effective manner. And the registry is designed to help you to do that. Next slide, please. With that, I'm going to turn this over to Dr. John Allen, who is the chair of the registry's Executive Management Board. John?
Thank you, Joel. I appreciate that. In the next few minutes, I want to describe the process of developing the measures and what the measures mean and how you can think about that within your own practice. The AGA's goal in practice is to help practicing physicians thrive in an era of uncertainty, and we certainly are in that era now. We are moving from traditional pay-for-performance, where one is rewarded for either following guidelines or some type of process measure, to a much more complex system where gastroenterologists will be integrated into larger systems and will have to prove their value in much different ways. A lot will depend on you proving your value in terms of managing populations of patients, particularly within concepts like accountable care organizations or with episode treatments or with episode bundled payments. The registry is designed to meet these needs in the coming years. It can certainly meet the needs of a practice's internal quality measures, looking at meaningful measures that during your practice, and also focusing on patient outcomes, not just process measures. It will meet the current needs for quality reporting programs for both commercial and federal programs, payers, purchasers, and also help move transparency to the patient level. Certainly benchmarking will be part of it, collecting data and being able to compare to local groups, other types of groups like you, regional groups, or even a national database, as Joel mentioned. And finally, what we consider probably the most important part is what's called population management for quality and cost. And we'll get into that in just a moment. Next slide, please. So what are the actual measures and what do they mean? When you think about these measures, traditionally we think about pay-for-performance measures as something, some sort of external entity created, either the federal government or payers. And we will be held to these measures. And if we are not held, if we don't meet certain standards, either our reimbursement will be decreased or will be placed in a higher cost tier or some other punitive measure. The measures within these databases and the AGA registry are really designed to help you understand your practice, to manage populations of patients, and be able to focus your efforts to bring patients that need specific care up to adequate levels. So we'll go through both of these fairly quickly, and then I'll turn this over to Joe Lynch to get into some of the details. So next slide. The development of these measures came from 3 different task forces that the AGA had pulled together with content experts from across the spectrums of practice and across the country to really look at what are the meaningful outcome measures that we could begin to develop. And for each of these measures, these are really fungible. They can be changed over time as different needs arise, but what they really do is define the data elements that are extracted from patient charts or an EMR to populate these measures. And those data elements can certainly create other measures or support other measures as time goes on. But the initial suggestions for measures are as follows in terms of colon cancer prevention. Was there an appropriate indication for the examination, most often colonoscopy? Is there a documented risk for colon cancer documented before a colonoscopy is performed? Colonoscopy process measures. Was this a complete exam? Was the prep quality adequate? And over time, what is your dynamic adenoma detection rate? And of course, this requires entering data on at least a subset of your colonoscopies by gender, or preferably all of the colonoscopies. What is the resource use? We know that the two major things that drive differences in costs are sedation use, particularly use of anesthesia professionals, and also the site of service. Procedure-related complications are available, specifically looking at the 14 days following the procedure. And then what are the recommendations for surveillance intervals based on the risk category after the procedure and after the pathology is back? Next slide. So some of the data that's already present in the AGA registry, as Joel mentioned, comes from the Moore-Squared database. And we've been able to download some examples here and provide this for you. So of those 4 million patients who have undergone colon cancer prevention testing, these can be split by race, can be split by group, can be split by gender very easily. And as Joel mentioned, this is a longitudinal database that can look at resource utilization and some of the outcomes over time. Next slide. We'll next turn to the inflammatory bowel disease performance measures. These were also created by several task forces of content experts. And concurrently, the AGA, in cooperation with the CCFA and other groups, have been developing measures for the National Quality Forum and PQRI. So there are a number of task forces put together, all really trying to develop meaningful measures for inflammatory bowel disease patients. So for example, are patients in steroid-free remission? And what was the mode of treatment used to achieve remission? Is there detection or avoidance of related infections, for example, with biologic therapy, tuberculosis, hepatitis? The assessment of risk for iatrogenic injury from medications, specifically around lab monitoring. The rate of guideline-recommended preventive services for the panel of patients you see with inflammatory bowel disease, osteoporosis screening, vaccinations, smoking cessation counseling. And what are the recommendations in terms of colon cancer surveillance? And again, these initial measures really define the data elements that come out of the patient charts. And new measures can be developed, certainly, as time goes on. Next slide. Again, from the 300,000 patients with inflammatory bowel disease, certain characteristics have been analyzed. For example, ulcerative colitis patients by age group, inflammatory bowel disease patients by diagnosis, and Crohn's disease patients by age group. These are data based on 300,000 patients spread throughout the country, and again, coming from the Moore-Squared database and its data entry into the AGA registry itself. Next slide. I'll now turn this over to Mr. Joe Lynch, who will talk about some of the details of data acquisition and the data registry itself. Joe?
John, Joel, thank you very much for that information prior to the registry. I'd like to now talk on a little more of a technical level on how data will be entered into and protected once within the AGA registry. Start off with some of the data security issues. The AGA registry is designed to gather data which are individually identifiable at the patient level. However, those data are protected and only transmitted as needed. So the minimum necessary amount of information is transferred from the data registry from the practice. The AGA registry currently maintains an industry-leading physical and electronic safeguards for all of the data security, both in the physician office as well as the servers that house the data. All patient data remain under the control of the practice, and that means the individually identifiable health information related to the patients that are treated at the practice remain under the control of that practice. And any data that are transmitted from the practice through the transactional data set on the web-based data collection tool or through any electronic medical record integration will be stripped of all direct identifiers, as that is defined in the HIPAA regulations. Those direct identifiers will be stripped, and a unique AGA registry identifier will be assigned to that particular patient, so that that patient cannot be re-identified. Practice level information, those would be aggregated results that can be reported at the practice level, or that each individual practitioner might be identified from those data, also remain under the control of the practice. Those data will not be released to any agency other than the practice without the expressed written permission of the practice involved. So there will be no data released to any payers, sponsors, or any other organization without the direct permission of the practice. The data that are submitted to the registry are analyzed in near real time and will be continually reported to the practice. As mentioned earlier, data will be reported back to the practice, both at the individual practice level. For some measures, we report it back at the physician level, and in some cases, those data will be reported back at the patient level, so that the practices can use those data to improve their healthcare delivery process. The next slide, please. And as I mentioned in the previous slide, there are 3 methods of data collection. 3 total. There are 2 devices, or 2 data points of entry into the registry. The first point of entry is through a web-based data collection tool that is provided, or to which access is provided without charge for all those participating in the AGA registry. For those participating in the AGA registry, there are 2 methods of submitting or selecting patients for the registry. There's a process of submitting 100% of all patients that meet the inclusion criteria for your practice. And for some practices, we realize that the burden of data entry associated with this selection methodology is substantial. So the AGA Registry Executive Management Board has made the decision to permit a sample of patients to be selected. Where 30 consecutive patients, your first 30 patients in a quarter, or whichever the method of selection, but it's 30 consecutive patients that meet the inclusion criteria for the registry will be entered into the registry, and those individuals will be followed throughout the course of their time in your practice, so that those patient data will be updated with each subsequent visit to your practice by that particular patient for those 30 patients. In subsequent training sessions, we'll explain to you how this patient selection process will occur and what steps to take when patients leave practice, or there are any other variations in that sample. The third method, which will hopefully be the most lucrative method of data entry for the AGA registry in terms of patient data submitted to the registry, is that of integration of the electronic medical record. There are 2 steps to the integration of the electronic medical record, or 2 types of integrated electronic medical records. The first is through a cooperative integration process where the electronic medical record vendor will supply data directly to the AGA registry through a certified data submission process. The second method is through a certified data integration system, where these data integrators will then cooperate or reverse engineer the electronic medical record that is a non-cooperative or unable to cooperate with the AGA registry. And through that process, we'll be able to map data directly from the electronic medical record into the AGA registry format for submission into the registry. There will be a fee. There will likely be fees associated with both the EMR integration, the cooperative EMR integration, as well as using the services of the data integrators associated with the registry. As these data integrators become contracted and the cooperative EMR vendors become certified, those fees and lists of companies will be published on the AGA registry website for you to review. Next slide, please. This slide is the first slide that shows you the web-based data collection tool that has been developed for the AGA registry. With this tool, on this page, we'll see some of the aspects of how data are entered into the registry. What is displayed now is information associated with the practice. With each practice, we gather all of the associated participating and data management staff, or the participating physicians and clinicians and data management staff for each practice, as well as each location associated with the practice. The reason behind gathering both all participating physician staff and locations is to be able to report information back in such a manner that would be able to permit each practice to identify any variations in care between physicians and also among locations. As you see on the left side of the screen, gives us the location of all of the practices associated with it. The center of the screen shows the current data being monitored. In this case, what we're looking to review is simply the primary address of the practice. The option to edit that primary address is located there in the center of the screen to the right as well. On the extreme right of the screen is the extreme right navigation screen, shows all of the practice users. That includes all the participating clinicians, as well as all of the data management staff that have been provided access to the AGA registry. Now, in terms of data management staff, data may be input by any participating physician, any registered nurse, physician assistants, or any practice staff that have been identified with and trained in the process of entering data into the registry. We will also be keeping track of those clinicians that are in the practice that are not participating in the AGA registry. Those will be termed treating clinicians, and in those cases, those are included so that we're able to gather information on all patients that have been treated in a patient panel that may be part of the physician panel, or sorry, the patient panel for each of the participating physicians, so we can have a continuous tracking of all the encounters for each of the individual patients. Now, on the bottom of the screen are the ability for us to select both new locations and for new users. May I have the next slide, please? On the next slide, what we'll begin to discuss is some of the information about the individual users. Each of the individual users, as I just explained before, will be listed now on what is now the left side of the screen. We'll have each of their profiles associated with the practice. So it'll show the user type, the user's name, their primary location, what their specialties, if they are in fact a participating clinician, and if they're also participating in the registry, what their registry account is, what their subscription type is, which means what through what point their contract is paid. On the far right navigation, in this case, what we're reviewing a participating clinician's user information. On the far right, we see the number of the patients that are assigned as part of this clinician's panel. If we were to select these individual patients, we'd move directly to the patient demographic screen for each of these individuals. But as we move through on the left navigation screen, each of the practice users has the similar practice panel, or the user information panel in the center. To add a new user, we'll merely select beneath the left navigation, would select that new user panel and would permit the registry manager to include additional data management staff or treating clinician staff. All participating users, all participating clinician data are entered in by the AGA registry staff, as that has an association with the participation agreement and a subscription fee associated with participating in the registry. On the next slide, what I'll begin to discuss are some of the patient demographics, some of the individual information about the patients in the registry. On this page, you move to what we would have selected on the right navigation of the previous slide was the patient information, the specific patient information, what will appear, and these are all the data that are collected for the patient. Now, as I said early in the presentation, each of these elements is individually identifiable health information. From that, we'll be selecting the first name, last name, and racial information, as well as sex and birth date. We'll also be selecting Social Security numbers for these patients. The reason for including these data in the data registry as it opposed in each of the individual practices is to permit us to have accurate longitudinal linking of encounter data across the term of the patient's participation in the registry, as well as the physician's participation in the registry. None of the individually identifiable health information that we gather in this registry are transmitted from the transactional data set that is used at the practice level to the data registry. So in all cases, any data reported from the AGA registry that is not reported directly from the transactional data set to the individual practice, or in terms of aggregated data back to the individual practice, none of those data are ever released in an individually identifiable or practice identifiable format from the AGA registry for any purposes without the expressed consent of each of the participating clinicians. And on the next slide, what I'll begin to discuss are some more details of the patient profile. On this page, what we're looking at is the overview of the individual patient profile. So on the previous slide, we discussed the individual components that go into the patient demographic screen, which you see displayed in the top center quadrant of these 4 quadrants on the screen. To the right, what we see is a listing of all recent events. In this particular case, what we see is the patient's had a series of medication changes and a series of tests that have been added, and at some point the history and physical information about this patient was updated in the data registry. On the bottom panel, you'll notice the history and physical information of this particular patient. On this page, Mr. Banks is 64 inches tall, weighs 150 pounds, is currently a smoker and has not had smoking cessation counseling. We also display the current medications for this patient. In this particular case, this patient is on mesalamine and infliximab and has had a second mesalamine adjustment. And on the next slide, what I'm going to begin to discuss are some of the encounter-specific information associated with this particular patient. What we see here is a list on the top panel. What we see here is a list of all of the encounters associated with this person. There are filters available for this screen, so that when multiple encounters have become added to this patient, the add encounter selection is to the right of this list. But when multiple encounters have been added to this patient, it allows the practice to filter both by the physician associated with that particular encounter, as well as the location of that encounter, if there are multiple locations where this patient might seek care. But here on the encounter detail selection, what we need to gather for each one of the encounters is the date of the encounter, the location of the encounter, the physician associated with the care rendered at this particular encounter. On the previous screen with patient demographic information, a responsible physician in the practice is assigned to each of these patients. What that permits is for us to report back information on a patient on a consistent basis to a single responsible patient, or I'm sorry, to a single responsible physician. In the event that a non-participating clinician treats a patient, the care rendered by that non-participating clinician will be attributed to the responsible physician, so that we have a continuous monitoring of patient care across the tenure of this patient's performance in the registry. We're also asking for the payer ID, the EDI, the Electronic Data Interchange ID, of the payer associated with each of the patients in the registry. The AGA registry will be providing you a shortcut to identify all the EDI payer IDs for each of the individual patients. And on the next slide, what I'll be talking about are some of the data that go into the history and physical associated with each of the encounters. In each case, when a patient comes into the data registry, what we will include are patient data that have not been changed or are new to the registry. So in every case when the patient comes to the registry, or I'm sorry, in the first case when the patient comes in the registry, all of these information will be input into the registry. This includes the height, the weight, whether or not they're a smoker, some of the conditions associated with that present their inclusion criteria in the registry, so their inflammatory bowel disease, if in fact they have that condition, or if they're in for colorectal cancer prevention, what those particular tests being performed were, be they in vitro screening modalities or if there is an actual colonoscopy performed. What this permits us to do by entering all those data in the first presentation to the registry is on subsequent encounters in the registry, what need only be entered into the history and physical or any of the other sessions in the screen are those things that change over time. So in multiple cases, when Ms. Goins presents to the registry again, we may only see changes in her weight or perhaps changes in some of the diagnostic modalities that have occurred in the registry or some adjustments to her medications. So in this history and physical screen, we may likely see only one or two elements that change going forward in the registry once the initial history and physical has been entered into the registry. And on the next screen, what I'll show you are some of the components that are associated with laboratory values. Laboratory values in the registries are very streamlined. We made a decision in the Measure Development Task Forces, the three teams that were working together to develop both the CRC, IBD measures, and some of the practice management groups, made a decision to keep these pretty short and simple. The two labs that are being captured in the AGA registry at this point in time for IBD and for colorectal cancer prevention are liver function tests and complete blood counts. So for the liver function tests, what we're capturing are whether or not the liver function test was within normal limits and the date of the examination. For complete blood count, we're also capturing a very minimal amount of information. We're looking at the patient's hemoglobin, their platelet count, their white blood cell count, and what the date of that procedure was as well. And on the next screen, I'll tell you about some of the tests and interventions that we'll be evaluating for the AGA registry. In this, we're capturing whether or not a in vitro screening examination was performed. In this case, we're looking at capsule endoscopy, CT colonography, dual contrast barium enema, whether or not a fecal DNA, fecal immunochemical test, a fecal occult blood test, or hemoccult were performed, or if there was a flexible sigmoidoscopy. In the event that those cases are performed, or those examinations are performed, we ask for the date of those examinations and whether or not the examination was positive, negative, or inconclusive. In addition to that, we are also capturing information about colonoscopy. In the colonoscopy screen, which I don't have a preview for you at this very moment, but in the colonoscopy screen, what we will be gathering are some detailed information about the procedure itself, whether or not there was an anesthesiologist performed, and what the risk of colorectal cancer both prior to the screening and after the screening or the colonoscopy were assessed, what the anesthesia risk for each of the individual patients was, and some other information about the procedure itself, sedation, the types of findings of the procedure, whether or not there were adenomas removed, and some other information about the procedure. But as we move forward on the next slide, we'll be talking about some of the medications that will be associated with the AGA registry. With the AGA registry, we are capturing data on these 5 categories of medications, looking at the aminosalicylates, the 5 ASAs that have been being administered for those patients with inflammatory bowel disease, whether or not the patient has been prescribed an antibiotic, specifically in ciprofloxacin, or if they have received a flagyl as well. We're looking at the biologic agents, the multiple types of biologic agents that have been approved for inflammatory bowel disease in the registry. And we're also looking to see whether or not a patient has been on corticosteroids. Now, understanding the complexity of medication administrations and trying to keep the data burden as minimal as necessary, in all of these cases, we're capturing information about the specific drug within these categories that the patient is being used, merely the name of the medication and the start date of the medication. If the medication is ongoing, the stop date will be left blank. It isn't to the point where the medication is stopped or the dose is changed significantly that a stop date will be added to the registry. For corticosteroids, more specifically, we're capturing information as to whether or not the patient is on a medication, a corticosteroid dose that is equivalent to 10 milligrams of prednisone within a 24-hour period. And on the next slide, what I'll be demonstrating for you are some of the reports that will be provided back to you within the AGA registry. In this case, it will be the cover of the executive summary. This report mock-up provides you a demonstration of how the performance measures within the registry will report it back to the practice. In this case, we demonstrate the 6 performance measures for colorectal cancer prevention on the top block. And in the first column, we show the rate of the practice, how that practice is performing on this particular measurement period. At this point, we're looking at a quarterly measurement period. How the practice is performing for this particular quarter. What percentile or what overall national rank that your practice falls into with this performance quarter. In this particular instance, we're looking at a rate of 85.6%, puts this practice in the 68th percentile for the identification of colorectal cancer prevention or the colorectal cancer risk. The next column, we're reporting what the mean rate of reporting of colorectal cancer risk is across the nation. Then we'll break down each of the percentiles, and in this case, we're showing the first and the top and bottom decile, and each of the quartiles in between, to give an idea of what where the practice falls and what the distribution of the nation's performance is. Then on the right, we show a box and whisker plot, which shows the precise location of the practice within the national distribution, indicating both the mean and the effective range of the performance across all sites across the country. We'll continue this same pattern throughout the 6 colorectal cancer prevention performance measures, as well as the 9 inflammatory bowel disease performance measures that have been demonstrated here. And throughout that, and what that'll do is that'll show how your practice is performing against itself, both and also at a national level. And on the next slide, what I'll show is begin to explain to you is the way data will be presented to your practice over time to allow individual benchmarking against the performance of the individual practice over time, as well as comparison groups both at a national and a peer level. And in some cases, we'll be able to perform a regional or local peer group as the data begin to support those degree of more specific stratification of benchmarks. And here we're showing benchmarks where the blue line represents the practice's performance over time, and these data will be reported on a rolling 4 quarters manner, so that displayed on this graphic, and in this graphic displays the 6 colorectal cancer prevention measures. So each of your practice data, as I said, in blue, will be displayed over 4 quarters each year, and each subsequent quarter will be added to the end, and the trailing quarter will be dropped off. In addition to that, on the red, we show a peer group level, and the peer group will be established by some of the characteristics of your practice: the patient size, the physician panel makeup, the number of physicians, the type of practice, and also the distribution of the practice, be they urban, rural, or suburban practices. And the third benchmark or comparative group that will be displayed on this graphic will be all practices participating in the registry or a national benchmark. And these will be displayed in each case for all of the colorectal cancer prevention measures, as well as the inflammatory bowel disease measures, to give a practice an idea of their performance both against themselves and how they compare to, and also how they compare to groups of similar size, and what the overall registry performance is. And on the next slide, what we'll be doing is beginning to entertain questions for the entire physician panel, both myself and Dr. Brill and Dr. Allen.
Thank you all for that overview. As Joe mentioned, we'll now take questions. If you have not already and you have a question, please be sure to type that into the question box on your screen. I'll read the questions and our speakers will answer them. Our first question is, and I'll ask you, Joe, to address this, please, is how is the data entered? Is there an interface available with certain EHRs? So I'll let Joe start off with that one.
As I mentioned earlier in one of the slides, there are multiple modalities for data entry. The primary modality is currently a web-based data collection tool, and for that there are two modalities. There's 100% submission of all patients that meet the inclusion criteria. The second is a sampling methodology where you can select where 30 consecutive patients will be entered and followed for the duration of the practice's participation in the registry. As it relates to electronic medical records, we are currently working with GMed to develop a cooperative integration with their systems to the AGA registry, whereby a certified data submission will occur from a participating practice that uses GMed. And as I mentioned, there will be additional fees associated with that data integration, but it will be a seamless integration where 100% of all included patients are reported without any additional effort from the practice. We are in discussions with other national electronic medical record vendors, and because of the nature of the discussions and that they're ongoing, we will be announcing those going as we move forward and get closer to the integration with those practices. For those practices that have electronic medical records that either are not participating or certified vendors for the AGA registry, or are certified vendors but have customized to a point where direct integration cannot occur, we'll be working with some data integration companies who specialize in mapping data from electronic medical records to submitting to electronic systems. With that data integration, there will also be a fee associated with it, but through that, a certified matching submission can occur from an electronic medical record that is not certified to the AGA registry. I know that's a lot of information and a long answer to what's actually a very complicated question. We'll have more information about this posted to the AGA website for you to download. And we'll also, as we certify these vendors will be listed on the website as AGA certified vendors.
Great. Thank you very much, Joe. The next question is, what is the pricing structure? Dr. Brill, could you address that, please?
Yes. For the physicians who are AGA members, it is $200, and a physician for an additional $150 can participate in the PQRI data submission process.
Okay, thank you very much. When will the registry be available, and what will be, whoops, I'm sorry, that one we've already. The question is, when will the registry be available? Dr. Allen, could you please answer that for us?
The registry right now is in beta testing and should be open, and Joe, you can confirm this too, should be open for data entry within the next 30 to 60 days.
It's actually, Dr. Allen, I'm happy to tell you that the days are actually a matter of hours.
Oh.
If we will be able to accommodate data entry as soon as a contract is submitted to the AGA registry as a participant. That beta testing period has concluded, and we're in the process of the final updates to the AGA registry web tool as well as data submission process. And we'll have pushed all of those changes to a live status as of tomorrow evening, close of business. So we will be able to submit to accommodate data entry immediately.
Excellent.
Great. Thank you. Also, just a point of clarification, the $200 is per year, not per month. So it's per AGA member per year. Just a point of clarification. Also, is there a reporting tool that can be customized so that customized reports can be generated? Joe, could you please address that?
I'd love to. The current process for developing reports is as you can imagine, is a very thoughtful process as we go forward with reports that are pushed out. We are developing ways of pushing out tools to practices that would allow them to do more sophisticated analysis of their data or their output. Conversely, until those more sophisticated tools are available to us to push out in a general manner to practices, we're going to enable the process of data downloads where data can be exported from the data registry at the practice level for manipulation by the practice, be it downloaded into an Excel spreadsheet that can then be imported into a software package like Access, where more sophisticated analysis can be performed, or through access to other analytic centers where they can even be imported into SAS or other more capable software packages. But as on the initial release of the AGA registry, there will not be any customized or customizable reporting programs. But as we move forward with these systems, there will be more customization.
Great, thank you. The next question is for Dr. Brill. Do you foresee penalties associated with the outcomes data if you fall below national standards?
I'll qualify my answer by saying that I'm simply speculating, because what Medicare, Medicaid, and commercial payers elect to do will be obviously what they elect to do. Having said that, Medicare has made it clear that during this decade it will start penalizing physicians who do not e-prescribe, do not have electronic health records, do not participate in PQRI. One could argue as to whether or not participation in those efforts would be equivalent to a quality standard, but nonetheless, the die has been cast, and by the middle of the decade, Medicare reimbursement will go down for those who do not participate. On the private payer side, what we've seen in other specialties have been a combination of things. Some payers have actually contracted individually for the physician and provided a higher reimbursement rate than the physician's peers for those physicians who participate in that payer's quality incentive or registry participation program. Other payers have developed bonus pools. For example, in California, a number of the health groups share in a bonus incentive pool which is payer-driven and is based on achieving certain quality standards. So I think that how this plays out over the next few years may be a little bit different from Medicare compared to the commercial payers, but certainly it's clear those who do not participate, certainly by the middle of this decade and going forward, will receive less than those who do.
Debbie, this is John. I'd like to clarify that a little bit too. I think there's a difference in terms of participating in programs like PQRI and participating in the registry. The registry, its structure, its measures are really owned by AGA and MedAssurance. So an insurance company could not come in and co-opt these measures and use the registry as a disincentive against the practice unless the practice would contract directly with a payer for that kind of program. So again, these data and the registry itself is really an infrastructure for you to manage patients and to demonstrate your own value. You can then take that and negotiate with either regional or national payers, but that would be your choice. If the AGA enters into some sort of arrangement with a payer, that would be a very transparent process that would be open for public and member opinion.
Thank you very much.
And if I could add to that last statement by Dr. Allen is not only would it be open to interpretation by member and payer opinion, but each participating practice would have to opt in to the program to have their data included in the program.
Correct.
Great. Thank you all. This next question is for Mr. Lynch. Obviously, the data entered is only as good as what is being entered. What are the measures to ensure that you are receiving accurate data?
That's a lifelong problem we have with observational data registries. We've built in a process to take a look at the data on the surface of the information. We have a series of data validations that occur both upon data entry and as well as on submission. We will perform some analysis on the percentage of missing fields and identify the individual patients that require additional information. But we also expect there are usual and valid ranges for just about every element that's being added into the registry. For instance, a procedure can't be performed before a patient's birth date or something to that effect, as well as there are some usual and valid ranges for each of the medications and results that are associated with the data that have been put into the registry. As it comes to things like PQRI and other performance initiatives, such as perhaps a pay-for-performance initiative by a third-party payer, with that will also come an audit program. The audit programs are under development now, and there's no immediate fear of or no immediate concerns for an on-site audit. But ultimately, with these pay-for-performance initiatives and other payment incentive or incentive programs for participating in the registry, will be required a program whereby the data will be audited, which will require an on-site review of a sample of patient records to verify and validate data that have been submitted to the program. So again, through another long-winded answer, what we've done is built in both upfront data checks to make sure that the data integrity, or at least the surface validity of the data, are addressed, but then the accuracy and final validity data can be assessed on a performance audit.
Great. Thank you, Joe. The next one, Dr. Allen, if you could address, we're transitioning to a different EMR. Should we wait until that transition is completed before we decide about the registry?
I think deciding about the registry is a separate issue. The method of data entry, as Joe Lynch has outlined, is really hopefully wide enough to allow flexibility. I think the choice of participating in the registry comes from how the practice views its quality improvement program and how it views the importance of managing panels of patients. So I think that's a separate issue. It will certainly take some time to integrate all of the major EMR vendors into the registry in a seamless manner. But the timing of that at the moment is not known. So I guess I would base that more on the desire of how you view your quality improvement program as opposed to the method of data entry, because I think there's flexibility enough to enter data in a number of different ways.
Thank you very much. Joel, Dr. Brill, could you please address how long the initial patient data entry takes to perform on average?
Well, if you're in an electronic system, it's obviously seamless, but for as one of the physicians who participated in the beta test that Joe Lynch described a few moments ago's time, the initial data entry only took a few moments' time, and then as part of the beta test, we did some follow-ups, and to do the follow-up entry, took less than a minute of time. It's really not that time-consuming once you get the hang of it.
Great. Thank you very much. This question actually we had received earlier in another forum, and I'm wondering, Dr. Allen, if you could address, do I have to enter all my patients that meet the inclusion criteria into the registry, and if I don't, then what happens?
There are two different ways to start the process of testing whether the registry is helpful to you. There is an option of entering 30 consecutive patients, and in some cases that will give a valid idea of how your quality is. Now, obviously, one cannot get a valid adenoma rate from 30 consecutive patients, but it will allow you at least to dip your toe into data registry. ideally, entering all patients would give the most valid answer for any of these questions, but I think there's a large range in between.
Terrific. Thanks very much. Dr. Brill, could you please address a question about polyp detection? It's being measured only for procedures such as colonoscopies. Is polyp detection being collected for any other procedure?
The registry measures as currently identified, and I'm not sure, I might not be answering the question that was posed specifically, but currently the registry measures that are been presented today and are available are only for the measure set that Dr. Allen and Mr. Lynch went through during this webcast. Certainly, one of the questions that people might have, and perhaps where this presenter is getting to, is that could the polyp detection be utilized for a PQRI or other measure? And in the future, this is a ongoing process which Joe may wish to address, but it is anticipated that as practices sign up for the registry, that there will also be expansion of the PQRI measure set at a point in the future, which might include the polyp measure in order to meet the goals of Measure 185 of the PQRI measure set. Joe, would you have anything else to add in that at this time?
I would, and if I can, I think the direct answer to the question is that all of the other modalities that I mentioned earlier will have merely qualitative results as to whether or not the screening test was normal, abnormal, or inconclusive. The only quantitative analysis of adenoma detection or polyp detection occurs in the colonoscopy report. So we're only looking at the actual colonoscopy procedure for the more quantitative analysis of the findings in the detection rate, or the findings in the procedure. As it relates to the PQRI measures, as we move forward and data are gathered and capabilities and requirements for the registry are further streamlined, also as we move forward to selecting new topics for the registry, how we can leverage the data collected for further reporting to initiatives such as PQRI will certainly be strongly considered.
Great. Thank you very much. In the interest of time, that will have been our last question. Thank you again to our speakers and to all our participants. The slides, the audio, and questions, those that we answered and those we were not able to get to, will be posted with answers on the website in about a week. We appreciate your taking the time to join us today. To enroll in the AGA registry or for more information, go to www.agaregistry.org. Send an email to info@agaregistry.org or call 877-809-9559. And I wish everyone a good afternoon, and thank you again for joining us.